I thank Dr. Patta Radhakrishna and Learning General Surgery for giving us an opportunity to talk on something which is very close to our heart. I wish everybody World Organ Donation Day. It's a very important day because it's a very noble thing to do, and we are here to make sure that the message of organ donation is passed through to the wider community. So, is my screen visible now?
Yeah, yes, it is.
Okay. So, what we are going to do is we are going to talk on brain death and the related multi-organ cadaver transplant with main emphasis on liver, kidney, and pancreas. So, I'm Dr. Chirag Desai. I'm going to moderate this, and we have three very experts as panelists. Dr. Sonal Asthana, who is a clinical lead, HPB surgery and multi-organ transplant, Esther, Bangalore. Dr. Ashish Sharma, who is a professor and head, Department of Renal Transplant Surgery at PGI Chandigarh. And Ms. Jaya Jairam, who is a center head, Mumbai, Mohan Foundation. So aim of this program is to increase the awareness about the concept of brain death and to increase the organ donation rate through that awareness and to spread the knowledge of multi-organ cadaver transplant amongst the surgical colleagues and the students of various courses. So in my first we will have 4 presentations and then we will have a question answer session. So we request all of you to send your question through chat, and after all the presentations, which will set up the scene and we'll cover most of the issues, and then we'll go through all the question answers to solve all the queries and to clarify the knowledge. So in my talk, I'm going to talk on how to define brain death, how to certify a brain death, what are the pathophysiological changes that occur in the body once the brain death sets in, and how to maintain and manage these donors before the organs are retrieved. So there are 3 types of death. One is cardiac death, respiratory death, and what we are talking about is the neurological death. It's a brain death. So death is an irreversible biological event that consists of permanent cessation of the critical function of the organism. But the brain death is an irreversible form of unconsciousness characterized by the loss of brain functions while the heart is still beating. So the concept of brain death came quite late after the concept of cardiac death. The brain death is defined as the irreversible loss of brain functions, including brain stem. In some countries, it is the whole brain death, which is a concept, while in some countries, it is just the brain stem death. The cessation of brain stem functions is the most important part because that is where most of the vital centers are located. Brain death occurs in response to increased intracranial pressure, which leads to fall in the blood flow to the brain, and that irreversibly damages the brain tissue. So this is the graphical presentation suggesting the same thing. This is the slide I borrowed from Dr. Ashish. So it clearly says that how the vicious cycle goes on. There is a neuronal injury that leads to a brain edema that increases intracranial pressure, that reduces blood flow, and that further damages the neuronal cells. So this continues for a while, and then intracranial pressure increases to such an extent that the blood flow to the brain stops, the brain cells are irreversibly damaged, and then ischemia spreads to the brain stem, and ultimately brain death occurs. In 1994, the government of India passed Transplantation of Human Organ Act, and this made it legal and official to consider a person with brain damage and brain death officially a dead person. Human organ and tissue transplantation was started in India since early 60s. However, initially the organ transplants were unregulated and there was possible organ trafficking. However, after this act was passed in 1994, it became slightly regularized and brain death concept became a reality. Then, like any other law, there were further amendments in 2011 and 2014, which improvised the law and to make it more user friendly as well as more clearer for the hospitals, patients, relatives, everybody. So all these amendments are a very important updation in this transplant brain death law. So every day the demand of the solid organ for transplant is increasing, and that is true for most solid organs: lungs, heart, liver, kidney, pancreas, even small bowel. So appropriate medical management of these potential donors and before they are identified as a donor and after they are identified as a donor till the organs are retrieved is very, very crucial. All available organs should be used and maintained in the best optimal condition to make sure that even after transplant, all these organs are functioning properly, and the ultimate motive of giving life to the patients is served. So this is the brain, which shows midbrain, pons, and medulla oblongata. So this is the brain stem. So this is the higher brain, and this is the brain stem. So when we talk about brain death, it is the death of this brain stem part which is most crucial, and it is the irreversible part. And once that part is damaged, it cannot improve or can be revived. And that concept has made the possibility of brain dead organ donation and organ transplantation possible. So these are the various cranial nerves which come from this different part of midbrain, pons, and medulla. So three integral part of brain death is irreversible coma, absence of brainstem reflexes, and apnea. So this trio is very, very important to establish that patient has brain death. So what is the process of brain death certification? First of all, we have to identify that there is a identifiable cause of the injury to the brain. So the usual causes are severe head injury, hypertensive intracranial hemorrhage, aneurysmal bleed, cerebroarterioid hemorrhage, hypoxic ischemic brain injury. And once that is done, it is very much important to exclude all those conditions which may have unconsciousness which is reversible. So extensive shock needs to be corrected and to be ruled out. Certain drugs which cause a similar effect have to be excluded. If there is brainstem encephalitis which may improve after the inflammation subside, has to be ruled out. Similarly, encephalopathy associated with liver failure or severe hypophosphatemia. So these are the exclusion criteria. So you have to exclude all this, and if any of this is present, then you should not progress further to go ahead with the testing. Then once that is done, then you have to perform clinical and neurological examination to establish coma, establish absence of brain stem reflexes, and establish apnea. So these all collectively establish that there is loss of brain stem function, and that is compatible and equivalent to brain stem death. There are situations where extra tests are needed, which are called ancillary or confirmatory tests, which are not regularly done, but done in a very, very specific situation. And as we go along, I will talk about them. And after all that, once we have established that this potential donor is a brain dead person and the family has agreed for the donation of the organs, it is very important to document everything properly. The time of death is very important, and which organs they have consented for the donation, and all those paperwork are very, very crucial and is integral part of the whole process. So, as I said, known irreversible cause has to be there. Exclusion of the potential reversible condition. You have to exclude hypothermia also. And once all that is done, the set of tests have to be done 6 hours apart at least 2 times. So this is very important. So just one set of tests is not enough. It has to be repeated after 6 to 12 hours by same or the different team, and we have to repeat the tests. So how do you establish coma? So there is no response to the painful stimuli, either to the nail bed or sternal rub or supraorbital reach pressure. So these are the common tests and very easy to do tests. And usually there is no interpersonal variation in this test. At the same time, the Glasgow Coma Scale has to be 3. Even 4 or 5 is not enough. It has to be absolute GCS 3 and lack of response to the painful stimuli. There should not be any response to the pain on the face, and brain dead person has a lack of this reflex. Then to establish the absence of brain stem function, these are the various tests: pupillary reflex, corneal reflex, gag reflex, cough reflex. All these tests are according to the cranial nerves. The first test that is done is pupillary reflex, and the light is thrown onto the eye, and you see the pupillary reaction. If it is present, that means the person is not brain dead. So in brain death situation, this reflex is absent. Similarly, the corneal reflex, it has to be absent at in the setting of brain death. Similarly, gag reflex or cough reflex is absent. This is another very important test, Doll side test. The normally an unconscious patient whose brain is still viable, when you rotate head, the eyes will roll to the other side. So this is known as doll's eye movement. Doll's eye movements are absent in presence of brain death. So this is a negative test. So if the doll's eye movement is present, it means the person is not brain dead. So this doll's eye test has to be negative. Similarly, oculovestibular or the cold calorie test, that is also opposite test. The positive cold calorie test indicates an intact brain stem, and hence if it is absent, that means the brain stem is not intact. Now the most important test is apnea test. So before this apnea test can be performed, it's very important that the body temperature is more than 36 degrees. The blood pressure, systolic blood pressure is more than 100 millimeter of mercury. The normal electrolytes profile within the acceptable range. The PaCO2 should be in the desired range. Then the person is given the pre-oxygenation first for at least 10 minutes. And then you constantly monitor SpO2 while doing the test. Then reduce the ventilatory setting, reduce the PEEP, and the first blood sample is taken. Then you disconnect the ventilator. Then during the test, the oxygen, 100% oxygen is given through the catheter, through the endotracheal tube. The ventilator is disconnected. This is observed for 8 to 10 minutes. All throughout the stability of the patient is observed. And if there is instability, then the test is aborted to prevent the sudden crashing of the patient. See, if there is no respiratory drive observed for up to 8 minutes, take the next sample of blood gas sample and reconnect the ventilator. If there is drop in the blood pressure or there is significant drop in SpO2, then the test is discontinued and it is deferred for a few more hours. The test is positive if the absolute PCO2 increases to 60 millimeter of mercury, or there is increase of 20 millimeter of mercury over the baseline PaCO2 in the first sample. So the apnea test is very important. It is repeated after 6 to 12 hours. Now, ancillary or the confirmatory tests are not routinely done in every patient, but they are done when the proximate cause of coma is not known. Apnea test is inconclusive, and when confounding conditions limit the clinical examination. So, which are these ancillary confirmatory tests? EEG, cerebral. So there is no activity on EEG. That suggests that there is no brain activity. There is no blood flow on cerebral angiography or MR angiography. So that suggests that there is no blood flow in the brain, so brain is dead. Similarly, the PET scan shows no activity. There is no take-up because there is no blood going there. Similarly, the nuclear scan shows the similar effect. It's blank in that area. So these are all ancillary tests. They are also known as confirmatory tests and done in a selective situation to confirm the presence of brain death when in doubt. So this is the diagram with the photographic representation of these tests. Now, once we have established that this person has brain death, then what are the pathophysiological changes that we expect in these patients? And this understanding helps us in the management and maintenance of this donor while we are waiting and preparing the recipients for the transplant. So brain death situation disturbs and disrupts central sympathoadrenergic regulation of circulation, and the pituitary temperature is also altered. There is an interruption of the hypothalamic pituitary adrenocortical regulation. The whole chain is disturbed. There is rising intracranial pressure, which results in massive release of pro and anti-inflammatory cytokines and catecholamines, which has effect on every organ and every system. And ultimately, when the brain death occurs, the loss of central regulatory mechanism occurs, which leads to hemodynamic change, hormonal imbalance, drop in temperature, and disturbance in the respiration. So the common physiological changes are cardiovascular, pulmonary, metabolic, and endocrine, in addition to the neurological changes. So what happens in cardiovascular changes? There is progressive ischemia from top to bottom. So initially, the first ischemia occurs in pons, then it progresses to medulla oblongata, and then it progresses to spinal cord. When the pons and medulla oblongata are affected, there is Cushing reflex, which is in response to increased intracranial pressure. There is hypertension and bradycardia. There is hypertension and bradycardia. But when this ischemia progresses to spinal cord, it leads to sudden peripheral vasodilatation, and this is in response to catecholamine surge. So initially there is hypertension and bradycardia, which later gets converted to hypotension needing support of inotropes. Similarly, myocardial infarction can occur because of massive catecholamine surge. Arrhythmia can occur, and even cardiac arrest can occur. So rate at which this ischemia progresses from top to bottom, these changes have time or no time to have a compensatory mechanism. Or if it is very fast, the physician has no time to intervene and to reverse the changes. But if it occurs slowly, or if the process is slowed down by intervention of intensive care unit, then this process can be slowed down, and probably we have a possibility of keeping these donors stable. Now, if we talk about endocrine changes, in 80% of the cases, the loss of the posterior pituitary function is very common, and this leads to lack of antidiuretic hormone, which develops diabetes insipidus. That leads to hypovolemia as well as electrolyte disturbance, especially hypernatremia, which is very crucial in case of liver transplant. And if left untreated, it can lead to polyuria, hypovolemic shock, and hyponatremia. In less number of patients, anterior pituitary is also affected, and that leads to change in the concentration of the thyroid hormone, adrenocorticotropic hormone, and the growth hormone. So initially they are normal, but later they get affected. Third endocrine change is hyperglycemia, which is multifactorial. So these are the various glands, how they get affected in case of brain death. Another pathophysiological change that we see in case of brain death situation is systemic inflammatory response. It is associated with trauma or any major illness or intracranial hemorrhage, which has originally brought patient to the hospital. Mediators are released from the damaged brain also. There is generalized ischemia, reperfusion injury mechanism. Then metabolic changes at the time of catecholamine storm can also lead to systemic inflammatory response, and failure to adequately restore the normal cardiovascular status can also contribute to this SIRS response. So this is indirectly observed that in all these patients who have significant systemic inflammatory response have high level of interleukin 6, and those patients who have very high level of interleukin 6 have a higher incidence of primary graft non-function or poor function. So it is very important that this inflammatory response is also blunted as far as possible by maintaining the patient in good condition and supporting them in ICU while we are waiting for and maintaining them for transplant. Similarly, hypothermia, stress, and metabolic changes occurs. Preventing hypothermia is very important. What are the causes of hypothermia in this situation? The loss of normal thermoregulatory control, exposure to cold ambient temperature, massive infusions of fluids as well as blood, reduced metabolic rate in these patients, excessive heat loss in this patient, and loss of vasoconstriction and shivering. So all this leads to hypothermia. So once hypothermia develops, it leads to difficulty in warming the patients. It affects the cardiac function. It leads to coagulopathy as well as arrhythmia, and it interferes with the oxygen delivery to the tissue. So to prevent all this right from beginning, these patients are cared for to maintain the temperature in the desired range. And the last is the hematological changes that we see in these patients with the brain death. There is anemia, coagulopathy, and there may be bleeding complications because of various changes that occur. The leukocyte count may also be elevated because of cerebral insults, systemic inflammatory response, and nosocomial infection. So in these patients when we are considering whether this patient can be considered as a donor or not, when the count is high, it doesn't always mean that there is ongoing sepsis, and just based on slightly raised WBC count, a donor should not and must not be rejected. So when these patients are identified, when we know the pathophysiology, when the organ death, brain death has been certified, we have to maintain this potential donors in a very stable conditions to make sure that we get the maximum benefit out of it and organs are preserved in a good state. So what are the goals while we are maintaining and managing these patients? So to maintain the cardiovascular stability is the first and foremost aim. So to maintain the optimal circulatory volume, use inotropes in optimal dose, neither too high or nor too less. Hormone replacement therapy in situation as the situation demands. Ensure adequate oxygenation by keeping patient on ventilator and adjusting the ventilatory mode, keeping lungs in a desired condition. Maintain the body temperature, not allowing it to cool down too much. Maintain adequate urine output. Prevent sepsis, and if little bit infection is present, to treat it. And by doing this, what we are doing is we are avoiding precipitation of the somatic death. After brain death, it takes a few hours to a couple of days before the heart stops. And it is this window of opportunity we are using to do the liver transplant, organ transplant. So our main goal eventually is to avoid somatic death. So these patients are intubated, ventilator, they are Riles tube in phase, Foley is in place, central line, arterial line, and in selected cases, especially if the heart and lung are to be used or the patient is very unstable, then Schwann-Ganz catheter is very useful. And obviously temperature probe is important to maintain the temperature. These are the routine blood tests are done, and depending on the various teams and the organs to be used, decides which tests are to be done. But these are the basic tests done for most transplant transplant donors. And the cultures are very important, though the results are not readily available. They need to be traced after 48 hours or so, and that guides the duration and the type of antibiotics to be used after transplant. And if at all the sepsis occurs after transplant in the recipient, this information helps very much. And if the culture report is already there, then it helps. Radiological tests in form of X-ray chest, sonography of the abdomen, looking at the liver, pancreas, as well as both the kidneys and the condition of the rest of the abdomen, any evidence of free fluid, the condition of the brain on CT scan, and in selected cases, if necessary, CT scan of the abdomen or the chest as the condition and the preference of the transplant team demands. It is observed that if, in spite of best efforts, 10 to 20% of the donors become suddenly unstable because of the rapid pathophysiological changes, and the organs are lost by loss of the donor. So to prevent that, it is very important that the aggressive multidisciplinary team takes care of these patients in the ICU to keep the organs in the best possible condition. And this may take few hours to a couple of days before the transplants are done. So therapeutic targets are so you have to maintain all these parameters in this desired range, and you have to manipulate the drugs and the strategies that you use to meet this magic figures. At times, there is competing physiological needs of various organs to be used, and that's why a good liaison between the ICU team and the respective transplant teams are very important to make sure that there is best quality maintained for all the organs. So for hypertension, obviously, antihypertensives are needed. For hypotension, vasoactive inotropes are needed. Usually balanced crystalline fluids are used. Synthetic starch is avoided. Excessive volume is also avoided. Transfusion of the blood and blood products is done as per the blood tests and the need. And the sodium level, especially in case of liver transplant patients, is very important. If the sodium level is very, very high, then the transplant is deferred for some time. Time is taken to bring the level down, preferably below 160, to have the best possible effect. But if the donor is otherwise going to be unstable, then this is accepted, and then the care is taken afterwards after transplant. Glycemic control is very important. Methylprednisolone, vasopressin, and thyroxine are the medicines which are used to maintain the homeostasis while we are waiting for the organ donation. In selected cases, N-acetylcysteine may be used. Obviously, PPI is used, and antimicrobials are used as per the local ICU protocol. So I think with this, my presentation part is over, and we can now ask Dr. Sona Sasthana to share his screen and deliver the second talk. Hello.
Hello, Chirag.
Yes.
Good evening, all. Thank you so much for.
Welcome, Dr. Sonal. I'm Dr. Patta Radhakrishna. I'm a Jipmarite. To introduce myself from the 1979 batch, I've been trying to get in touch with you for quite a while now, but nice seeing you. Welcome.
Sonal is a very busy person on the day of organ donation day. Demand all over the place.
No, thank you, Dr. Radhakrishna. My apologies to you. I really owe them because I know that I've been very tardy in replying to some of your messages. And thank you so much for including me as part of this this meeting. When Chirag reached out to me and I knew that you were involved as well, I thought this is an opportunity for two birds with one stone, because I can associate with two people who I greatly admire and respect. Today, obviously, Chirag has just set the scene very well when it comes to setting up how one has to test for brain death and how an organ donor has to be maintained. I'm going to take the next step forward here and talk a little bit about about basically organ retrieval. What are the pros and cons? How do we consider someone for an organ retrieval? What are the steps that we follow for a patient who's going to be taken up for organ retrieval, which include the operative steps, as well as some of the new things that might that have come up, which might be of interest to the audience here. So, okay, is my screen visible?
Yeah.
Okay, perfect. So essentially, as discussed, the mandate today was to talk about a background which has been covered in some detail by Dr. Chirag. Talk about the indications, contraindications for both. How do we accept a person as a potential deceased donor, as well as who would be a suitable recipient for from a liver perspective. We also talk about the principles of organ allocation, because this is a very interesting boundary in terms of technique, in terms of logistics, as well as in terms of ethics and equity of healthcare. So there a lot of transplant has to do with ethics and practice, and this is perhaps one of the more interesting and challenging parts of being a transplant surgeon. The organ retrieval process, as well as some recent advances. So to talk about milestones in transplantation, transplant as we know it today, solid organ transplantation is just over 65 years old. The first successful kidney transplant was done in 1954, and actually for surgeons it's good to know that the surgeon who did it, Dr. Joseph Murray, was the last surgeon to receive a Nobel Prize. So the best way to get a Nobel Prize is to be involved in transplantation in some way. I'm just recruiting future surgeons for transplantation in the future, possible. Liver transplant was attempted in 1963, done successfully in 1967, but it wasn't until 1988 till transplants became mainstream. And it wasn't until 1998 that adult to adult living donor transplant actually also went mainstream. When you look at India, India actually had a fairly early start. The first kidney transplant was attempted in 1965 at KEM Hospital. The first deceased organ transplant was attempted in Apollo Hospital, Chennai in 1994, just after the passage of our law, the Human Organ Transplantation Act. 1998 was when a transplant was attempted at AIIMS. The first successful transplant was just done about 19 years ago, and today India is one of the largest transplant countries in the world by numbers of transplants done. So we've talked about the Transplantation of Human Organs Act. It is a good act. It has had 3 amendments which have actually made it much more user-friendly and fit for purpose in terms of preventing commercial organ trafficking, as well as laying out the pros and cons of who can and who cannot donate. Of course, it goes without saying that transplantation needs organ donors. And a lot of patients come to us assuming that we have organs available in a fridge handy somewhere, which you can actually pick up and transplant in people. I wish this was the make a transplant surgeon's life so much simpler. But unfortunately, that's not the case. There is a very big gap between demand and supply. We reckon that about 20,000 people need a liver transplant in India every year, and the number of people who get a deceased donor transplant are less than 700 to 800, while a majority of people receive living donor transplants. So when we talk about who cannot be considered for deceased donation, as of now, because of changing rules and changing technical advances, there are a lot of candidates who were potentially perhaps not suitable for organ donation before, who can now be considered for organ donation. As of now, we can say that uncontrolled sepsis, uncontrolled malignancy are probably the only two absolute contraindications for deceased donation. Everything else can actually be managed, everything else can be controlled. And over the last few years, we have seen successful organ donation programs that now encompass patients with hepatitis B, hepatitis C, or HIV infection, as well as controlled malignancy. So all these used to be contraindications in the past 5 or 10 years ago, but these are all relative contraindications now. And most importantly, you must remember that age is not a bar for liver donation. The oldest person to donate organs in India was 88 years old, who was the trustee of Sir Gangaram Hospital, and his liver was actually used successfully for a recipient. So the oldest donor from a liver perspective in India was 88 years old. And this is just to give you a perspective of how long organs can last. So this is one of the first girls transplanted by Sir Thomas Tazel in 1970 for biliary atresia. You can see her picture looking a bit yellow and jaundiced in the first picture pre-transplant. 6 months ago, looking very healthy without jaundice. And this was a picture taken in 2015. So she is the longest survivor after a liver transplant, almost 45 years after a liver transplant. So one of the things that makes liver transplant so rewarding is that these organs can last for a very, very, very long time. How do we select the recipients about who should get an organ? So again, we start with who should not get an organ. Patients who have AIDS, not HIV infection, but uncontrolled AIDS because of, as a consequence, are contraindicated, as active alcoholism and substance abuse. People who have advanced comorbidity, patients who have an anatomical abnormality that precludes liver transplant. This group is growing smaller and smaller as we get better with our technique. People who have malignancy outside the liver and who are non-compliant with medication. Again, sepsis makes an entry. People who have got active infection cannot receive a transplant because it involves immunosuppression. What are the indications for liver transplant? Of course, the liver failing for any reason. End-stage liver disease, as is defined by either a consequence of hepatocellular failure or portal hypertension as a consequence of liver cirrhosis. So acute liver failure is one reason. Decompensated cirrhosis is the commonest cause for liver transplant, which may occur as a consequence of alcoholic liver disease, non-alcoholic steatohepatitis, which is a very large part of our practice today, or any other reason for which livers can fail. Liver cancer is another reason for transplantation. Metabolic disorders are common indications for transplantation in children, as well as systemic complications of chronic liver disease, such as hepatopulmonary syndrome. One can also add chronic pruritus as a consequence of, say, cholestatic liver disease because of primary sclerosing cholangitis, which form a lifestyle indication for liver transplantation. So to understand how transplant fits into the scenario for chronic liver disease, one must understand the natural history of chronic liver disease. So most patients with chronic liver disease are stable cirrhotics. They go on to develop compensated cirrhosis, where the patient is able to manage a completely normal lifestyle without actually having any decompensation or challenges. The patients with compensated cirrhosis tip over to decompensated cirrhosis because of some sort of precipitating event. In our country, it is usually some sort of infection. It can be a GI bleed. It can be the development of encephalopathy, jaundice, ascites, or hepatorenal syndrome. And patients who have decompensated cirrhosis actually go on and die if they are not treated. And this tipping point of compensated to decompensated cirrhosis actually makes the difference. So compensated cirrhotics can live for a very long time. The median survival is almost 9 years. So if you have a patient who comes to your OPD with just cirrhosis as a radiological finding, absolutely normal biochemistry, no features of decompensation, then all they need is regular follow-up. They do not need a referral for transplantation. But patients who have developed decomposition in the form of ascites, a GI bleed, a tumor, encephalopathy, or infection need to be considered for transplantation. But as you can see, the median survival is approximately 18 months for these patients. So how do we make sure that we assess these patients in a standard fashion? So this was done by the introduction of the MELD score, the Mortality by End-Stage Liver Disease score, that was introduced in 2001 as a model for predicting the severity of cirrhosis. This model actually predicts the risk of death in a patient with cirrhosis based on absolutely numerical criteria such as bilirubin, INR, creatinine, and sodium. If you plug them into the formula, then you get a number. The higher the number, the higher the risk of a person dying within 90 days of liver disease. So based on the score of the MELD, the higher score, we were able to design a model by which you could select who needed a transplant and who should be prioritized for a transplant. For example, if an organ became available, who should get the organ between one person and another person. So to summarize, patients with cirrhosis who develop complications such as ascites, bacterial peritonitis, encephalopathy, variceal bleed, or who have poor quality of life should be considered for a transplant. And patients who do not have complications but have a high MELD score, a score of more than 15, that usually translates into a bilirubin of more than 3 milligrams per deciliter or an INR of more than 1.5, should be considered for a transplant. This slide is just put up to show that patients with tumor, hepatocellular carcinoma that is limited to the liver, can be considered for a transplant. So having a hepatocellular carcinoma is not a contraindication for transplant, as long as the tumor is confined to being within the liver and without any major vascular invasion. So how does one select donors and recipients? This is a very important point when it comes to equity and allocation. In India, all allocation is decided by states because healthcare is a state law, but there is a broad consensus about a few things. One is that decision making should involve an explicit evaluation of the risks and the benefits. So for example, if you have a very marginal organ that is coming from a very older person or a fatty liver or a poorly maintained donor, and you have a completely stable patient, then perhaps that recipient is not the right person to get the organ. So we have to do a risk and benefit allocation of the potential recipient based on the information that is available to us, as well as an appropriate use of scarce health resource. Again, they should be inclusive and equity. You cannot distinguish between potential recipients on the basis of race, religion, gender, marital status, sexual orientation, other things. And you cannot hold a person's previous lifestyle against that person if you are sure that this compliance is not going to be affected. So patients who have had challenges with alcohol but have demonstrated that they're able to quit alcohol and comply with medication are probably good candidates to be considered for transplantation, because it would actually give them a new lease of life. Unfortunately, in our country, the third thing is the biggest sort of drawback, because the capacity to pay for treatment actually determines whether or not somebody can get a transplant. The factors that are irrelevant are relative urgency of need, that is normally calculated by whether a person has acute liver failure or not. A medical factors by affect likelihood of success, the relative severity of liver disease, what is the quality of life of the recipient, and of course compliance. So practically, most systems across the country would use urgency, acute liver failure, chronic liver disease, a hepatic artery thrombosis, a primary non-function of a previous organ. These would be the orders of priority. The MELD score. We also consider the body weight. Clearly, if you have an organ coming from a 100 kilo person, you cannot give it to a 50 kilo person or to a child. Pediatric and small bodied patients typically get preference in most organ allocations because it is very difficult for a child to get an organ in a normal allocation system. And of course, we have to see how marginal organs should be factored in. Marginal because of age, the cold ischemia time, or donor instability. Again, now switching gears a little bit and talking about organ retrieval. Now, this is a process that is typically done by transplant teams, but should actually be learned by most people who are taking care of sick patients, because organ retrieval is a very important skill to know. It's important to have a logistical team that is able to safely recover organs and transport them to transplant centers. How are organs minimized? The important thing that you must know, the cornerstone of organ retrieval and across the world is basically making sure that the blood is flushed out of these organs, is replaced by a special preservative solution, Here I've just shown one such solution which is called University of Wisconsin solution, which basically uses a buffer. It uses osmotically active ingredients to prevent the cells from swelling up, and of course cooling down of the organ. So we try to get the temperature as close to 4 degrees as possible to decrease the cellular metabolism. Because if you can decrease the temperature from 38 degrees to 4 degrees, you can slow the metabolism time down almost 10 times. So if we are able to cool an organ and use these solutions, we can maintain an organ, a liver, for almost 6 to 8 hours, a kidney for about 12 to 14 hours, maybe longer, pancreas for approximately the same amount of time, and a heart for about 4 to 6 hours. So when we plan an organ retrieval operation, these logistics are extremely important. So when we cross clamp it, we must make sure that the organ that we ship to whichever recipient center is ready for implant, the liver in approximately 6 to 8 hours, the kidney in 10 to 12 hours, and the heart in a shorter period of time. So this logistical organization is actually the most important part of a transplant coordinator's role when we are planning a multi-organ retrieval. Very quickly going through some of the steps, I would encourage all of you who have not taken part in organ retrieval to please do that, because this is perhaps the best anatomical operation that you will ever see in terms of understanding the anatomy of all the organs in the abdomen. These slides have been given to me by Dr. Rehan Saif, my ex-colleague. So I'll just run you through them. Basically, you drape from the suprasternal notch to pubis. You have to make a big incision starting at the suprasternal notch and going down to the pubis. We seldom require lateral extensions because this long autopsy-style incision typically will give good exposure to all the thoracic and abdominal organs. After exposing the patient, one must do an inspection of all the organs. Here you can see that the heart is exposed, the pericardium is open, and the liver is exposed. The retractors are used here for thorax and abdomen. Basically, this is for demonstration. You can see that here, right and the left lungs are there, and you can see the infradiaphragmatic part showing the different parts of the abdominal cavity. So the first part of organ retrieval is running the bowel, doing a complete laparotomy to make sure that there are no contraindications to donation. So I would probably have done close to 3,000 retrievals or been part of that in the part of the 17 years that I've been involved with transplant. And on 3 separate occasions, we have found tumors, one in the pancreas and 2 in the colon, that have actually precluded us from using those organs. So often you can find findings that are incidental or not previously known about donors. So it's important to do a good laparotomy. So after doing a laparotomy, one must take a look inside. You should look at the liver, examine the liver. So firstly, you must feel the liver consistency. Is it soft? Are the edges sharp? And when you press it, does it blanch to a yellow color? Is it fatty? These findings have to be communicated to the recipient team. So there has to be a good ongoing communication between the retrieval team and the implanting team so that the implanting team can be ready for quality as well as anatomical details of the organ that is going to come. So firstly, you have to start with the cattle branch maneuver. You first do a mobilization of the right colon. You then cauterize. Here you can see the IVC and the left renal vein. The duodenum is mobilized in order to get control of the vessels. After this mobilization, you expose the great vessels, the IVC, as shown here. As you can see here, the IVC is exposed. The next step is exposing the lower end of the infrarenal aorta, that is starting at the bifurcation of the iliac vessels, so that we get control of the iliacs as well as the lower aorta. This is for introducing the cannula in order to flush the abdominal organs. Here you can see the next step after the laparotomy and mobilization is that the cava and the aorta are slung and mobilized. Then one must mobilize the liver, as seen here. You want to take the left triangular ligament down and then look at the hepatoduodenal ligament. This is an important maneuver because any aberrant left hepatic arteries which arise from the left gastric will be found just about here. This is the place just below the left lobe where an accessory left artery will be found. So it's important to map out any aberrant anatomy while at the time of retrieval, because this has to be communicated and these arteries have to be preserved. After this, the esophagus is mobilized and the right crest of the diaphragm is divided, because this gives you access to the supraceliac aorta for control. As you can see here, you can see that the iliac aorta is slung. This is important also for people who are doing trauma work on a regular basis. If you have a patient who comes to you with severe uncontrolled bleeding from the abdominal cavity, an important thing to do is to just simply mobilize the left lobe, get control of the supraceliac aorta, and clamp it. That is often a life-saving maneuver in trauma. So it's important to know this particular vascular technique, because it can get you out of serious trouble when it comes to dealing with unstable patients sometimes. The next step here is freeing out the portal structures. You go to the hepatoduodenal ligament, identify the common bile duct. As you can see, the pancreas there and the duodenum. The bile duct is divided. The artery is identified. You can see the gastroduodenal artery over here and the common hepatic artery. One should be very careful to not tie the gastroduodenal artery early on for two reasons, as Dr. Ashish is going to talk as well about the GDA being an important part or a marker for pancreas retrieval, but also understanding that a number of patients do have celiac stenosis, and the GDA is often an important source of collateral blood flow to the liver. So one should not tie this until the cold phase of retrieval. After this, we divide the common bile duct. You can see the common bile duct is going to be cut, which exposes the portal vein. We should also flush out the common bile duct with saline, because you must remember that once the liver cools down, then the bile inside the bile duct will become very solid. It can congeal and form almost like stones. This can cause secondary biliary obstruction in a liver transplant recipient as well. So this is important to ensure that the bile duct are flushed out. So what I'm going to talk to you about is single aortic cannulation, although dual aortic cannulation is also described, where a separate cannula is put into the inferior mesenteric vein. But typically what most centers would do to cannula into the aorta here, clamp the aorta on the top at the iliac below or above near the chest, so that the circulation of the preservative solution is limited only to the abdominal organs. Okay. So basically, this is what has been done. In this case, the cava is vented down. You can see the lower end. This is the lower end of the aorta, the left renal vein, both have been introduced. So firstly, once this is done, then you have to coordinate with the other teams. This is called the period of cross clamp. We clamp the aorta on top. We start perfusion, and then we vent the cava so that the blood can come out. Make sure that the outflow is good, make sure the perfusion is good. And at the same time, we have to start to cool the liver and the abdominal cavity down. As we discussed before, we have to get the temperature down to 4 degrees so that the organs can be viable. So this is called the cold phase of retrieval. Once we have identified all the structures, we start flushing it with preservative solutions, typically about 5 to 6 liters of UW, and cool the organs down rapidly. After that, the next stage is called the cold phase, where all the organs have to be retrieved intact with all the vascular structures. And in the case of the liver, we have to do it with a patch of the aorta that includes the celiac artery and the SMA, as well as a good length of the portal vein. We leave a little bit of the portal vein for our pancreas colleagues so that they can also do a safe implantation. As you can see here, this finger is actually in the top part of the vena cava that goes to the heart, and then the liver is lifted out and freed up from its diaphragmatic attachments, as in here. We remove a large part of the diaphragm as well to safely remove the liver without causing any damages, and this is what it looks like in the backbench. So basically, we have to flush it through with preservative solution again, make sure all the fluid is nice and clean without any blood, and preserve it accordingly. So kidneys are not going to go into. We typically do en bloc retrievals, and these are separated on the bench. And then after all the retrievals, we have to make sure that we do a very neat and clean closure of the abdomen. So most surgeons tend to run away at this time. This is not correct, because this person and this family has taken a great deal of trouble to donate organs so that 8 people can live. The least that a surgeon can do from this side is to make sure that we respect the family's wishes and their sacrifice, and we do as good a job as possible. So it's important to do a subcuticular stitch, make sure that you do as clean a closure as possible, so that the family doesn't regret their decision of organ retrieval. And one of the things that we do is to train a standardized course on organ retrieval, which we'd be very happy to restart once the corona pandemic is over. So, as I've also mentioned before, a lot of people who were potentially not candidates for organ donation before have become organ donors, potential organ donors now. Now we are taking on more and more organs which were considered marginal. And this is possible because of technology. Organ donation in our country has increased substantially. The organ donation rates have increased almost 11 times in the last 7 years. And we have seen that the center of gravity for organ retrieval has changed from large cities, large cities like Chennai, like Mumbai, to smaller cities like Indore, Nagpur, for example, and for Belgaum or Hubli, for example, in Karnataka. So donations are happening in smaller cities, which is good, but there are logistical challenges of transporting organs. So organs might be present in patients and donors who are poorly preserved, in places where the cold ischemia time would not permit travel between city retrieving the organ and to a transplanting center. So while we have shown an increase in the organ donation rates, now deceased organ donations actually form 20% of all the transplants done in India. Until we address these last mile challenges, we will never be able to fully harness the potential of organ retrieval. And this is where this kind of technology, that is the Organox technology, that normothermic machine perfusion, comes in. So very simply, this is a mechanism of keeping the liver alive and sentient outside the body. So this is whole blood, 4 units of whole blood, which is then connected through a pulsatile pump, an oxygenator, as well as with a TPN bag containing nutrients that go into the liver and perfuse the liver while it's sitting outside. So this liver can be perfused as if it's sitting outside in a box, as if it is in the body, and it can be maintained at normal state. So even livers that are potentially fatty can then be utilized without giving them the trauma of ischemia reperfusion. So this kind of machine actually is very useful because it helps to circumvent a lot of problems. So in India, for example, if you have a donor that is 12 hours away, an organ can be retrieved and put on a machine and then transported to a transplant center. So it can allow us to coordinate time logistics. In some cases, when the liver has not been well managed in a donor, when the blood pressure has been low, the NMP can allow us to nurse the liver back to health. It allows the liver to recover its function so that all the bad effects of ischemia reperfusion are taken care of. It can help us to coordinate the transplant activity a little bit better. And of course, if some organs, when you put them in the machine, do not behave well, if the acid levels continue to be high, you can actually make a decision that this organ is not transplantable in a much more educated fashion. So I'm not going to go into too much detail here. Our team was the first team to use this machine in Asia. We were only the third country in the world to actually use this, but it was available to us for a very short period of time. And this is the first organ that we put on. Please see that the liver here is very fatty, and there are these tubes that are draining into the portal vein, the hepatic artery here, and also draining the cava. So what I'd like to show, if I can, one second, sorry. I'm just going to try and show you this video because it's an interesting video to see.
So what he said was ki check for.
Yeah. So now you can see that as blood starts to flow into this particular liver, you can see that the liver starts to reanimate while it is sitting in a basket. So you can see that pale dead liver completely coming to life as blood starts to flow in and out of this. And here you can actually see the liver start to produce bile as well. So you can actually see the liver start to demonstrate function while it is sitting in the basket. So this is ex vivo liver perfusion with blood, which is called normothermic machine perfusion. And I think this is probably the most significant advance that we have seen in liver perfusion technology in the last 50 years. So this was the patient that we used it for, and as you can see, there was a substantial amount of fat, almost 60% fat before the liver transplant. And when we did the transplant, there was hardly any change in the inflammation. And although the enzyme levels increased significantly, but they were down to near normal in a very short period of time. This was the team that actually did the transplant. You can see Professor Darius Mirza there from Birmingham in the UK, who actually very kindly came down to help us go through this. He's actually one of the founding members of the company that developed the technology behind this particular this thing. So all I can say right now is that organ donation is a very complex logistical challenge. There are very clear definitions of who can be a donor and who can be a recipient. And because of advances in technology, we are going even further in increasing the number of people who can potentially donate. Organ retrieval is a standardized surgical process, and I think that every surgeon should actually at least witness or be part of organ retrievals, because at the very least it gives a very good understanding of abdominal anatomy. Thank you so much for your time.
Thank you, Sonal. That was very informative and quite comprehensive. So now we can go on to the next talk by Dr. Ashish, and he'll mainly address pancreas and kidney part of it.
Yeah, good evening. Good evening, Sonal. Am I audible?
Yes. You can share your screen now, yes.
Okay, so is the screen visible?
Yes, it is.
Yeah, so Sonal has laid a solid background for me to talk, and he's talked about organ retrieval and the role of surgeons and why should the general surgeons be involved, and the organ transplant activity across the country, which is increasing. I think it's all looks very promising for the future to be a transplant surgeon. And before I start, I would acknowledge my colleagues who could actually make and participate, make all these videos and pictures for me. And just to give another overview of the history, like I'm fortunate to be in a department which has been involved in the first renal transplant since June 1973, and we did the first disease donor in 1977. And so it's one of the earliest centers to establish kidney transplant in the country. We started doing donations after cardiac death. We heard about the brain death and the brain stem death, but then we can also get organs from patients whose heart has stopped working, and we did our first transplant in 2012 and have performed more than 25 transplants from such patients. A couple of years down the line, we did our first pancreas transplant, and again done about 25 of these transplants so far. A separate department was established in year 2005. Before that, it was just we were just part of the general surgery. It's got a 9-bedded ICU with very state-of-the-art facilities. We do about 250 kidney transplants every year, around 1,200 dialysis access procedures in a year, with 40 diseased organ retrievals, apart from other general surgical procedures in kidney transplant or CKD patients, and some vascular surgical procedures as well. So it's a fairly busy program, and we always had training positions of senior residents who would come and stay with us for about 3 years, and then they would go out, work in separate areas. And this was always a dream to start a training position in transplant surgery in our country. And last couple of years back, we could start our fellowship in kidney and pancreas transplant surgery, which was a 1-year program for established surgeons who want to brush up their knowledge. And last year, we actually started the first MCH in the transplant surgery in our country. And I'm glad to announce that the first person to join us is from All India Institute of Medical Sciences. And you would be amazed to know that 3 of alumni, is a small department, and 3 of its alumni actually has been awarded the highest civilian award in the country. So transplant can bring to you a lot of laurels, as Sonal said. So it's worth pursuing this goal. So, I mean, I was supposed to talk a lot of things about organ donation and transplant, and then we split, and some things have already been shared. So I'll just repeat those, or maybe I'll just present my videos if time permits. So I'll talk briefly about the organ preservation. How do we preserve organs? And what is commonly taught and commonly known is that organs can be preserved in the cold. We have to know that it is not only the cold which is damaging the organs. The organs can be damaged even before they are put into the cold. So I just thought that I'll just elucidate the types of injury the organs they undergo while in the process of organ donation and retrieval. So you can have a pre-preservation injury before the organ is actually put on the ice. So which can be in the form of a pre-existing disease, as Sonal said, that you can have a fatty liver, you can have a patient with the acute kidney insult because of dehydration or because of shock, your creatinine may rise. So all those can be pre-existing in the donor as such. And then there is injury associated with brain death, as Dr. Chirag mentioned, that brain death is associated with a lot of catecholamine release, which can cause critical ischemia of the organs, if not, especially during the phase when the patient becomes hypertensive. So those things, if they're not managed well, they can cause organ injury as well. During organ harvesting, also you can cause more damage to the organs, especially if your donors are not being managed well during the theater. What happens is the anesthetist, one anesthetist says, okay, there's no anesthesia involved, so he might just relax and your BP may go up and down, and if you're not informed, so your organs can again have an ischemic insult. And more important than that, that if you are not careful with handling of your vascular structures, they are very prone to go into spasm. So if you pull and push the organs or the associated vessels a lot, you can cause actually ischemic damage of the organs, which can present as delayed graft function. So all these can be prevented with the careful management and better handling of the organs during the operative procedure. So the major focus of preservation is while we keep the organs in the cold, as we know that it's impossible to put the organs right away. We don't have those, we need to have some time to prepare the recipients, to prepare the bed for the organs to be placed. So we need to keep the organs in the cold. So, and we know that when the organ is in the cold, it is not oxygenated, and you have an anaerobic metabolism, which leads to a lot of free radical generation and a lot of end products of anaerobic glycolysis, which are damaging to the cell itself. And most importantly, you've got a sodium potassium ATPase, which is dependent upon the energy. And if this pump is blocked, what happens is that the potassium goes out from the cell, and which results in cellular swelling, which again causes ischemia of the organs. So to overcome this, we have the cryopreservative solutions, or if you go to the modern era, you probably, or if you go into the future, you probably will have the warm storage system like Organus, as Dr. Sonal showed. So apart from this, you can also have a rewarming injury. Remember that the goal to put the organ in the ice is to keep the organ at 4 degrees centigrade. But when you're doing your anastomosis, it's impossible to maintain that temperature in the patient's body, in the recipient's body, while you're doing the anastomosis. And if you take too much of time to perform that anastomosis, again, your organs they may not perform as well, and they may go into a phase of delayed graft function, which may sometimes be fatal for the recipient, especially if you're doing a liver transplant. And lastly, you have a reperfusion injury, that you have an organ which has got a lot of free radicals and reactive oxygen species. And as soon as you perfuse the organ, the blood actually leads to a lot of lipid peroxidation of the cellular membranes and causes cell destruction. So you need to know that at the moment there is nothing with which we can actually prevent this insult. But then there are some additives to the storage solution which can lead to prevention of this type of injury. So the preservative solutions, as Sonal highlighted, is like this is the basic. So you want to prevent that cell swelling because of the loss of function of sodium, potassium, ATPase, and as we know that all cells have high potassium content. So if you give a solution, if you put the potassium inside in the solution, and so your cellular edema can be prevented to some extent, or you can put some impermeant solutes like glucose, raffinose, hydroxyethyl starch, which will not they will prevent from the water from going inside the cell and will try to retain the water in the extracellular compartment. We know that during anaerobic metabolism, acidosis happens. So you need to have some buffers like phosphates, so which can prevent that acidosis to develop. And you can have some antioxidants which will prevent your free radical injury, especially during reperfusion or during the storage phase. You can add some as vasodilators, and you can add energy sources. So that's a basic concept. So all solutions, they just move around the same, only the solutes and the composition may be different. And the urocolins was the first solution which was made available across the world, and this was based on it being isotonic with a very high potassium content, and used glucose as an impermeant. So that was the basis of using urocolins, and then it actually increased the preservation time, but only till about 6 hours, and then it was modified to further increase the preservation time to about 12 hours. But then that was the limit for even the modified urocolin solution. And then the more and more newer solutions came. We have the University of Wisconsin solution, which is one of the commonest solutions used across the world. And there we have the hydroxyethyl starch to prevent the cellular edema, and same other substrates are added along with dexamethasone. And another popular solution is the HTK solution, which uses histidine as a buffer, and tryptophan to prevent your membrane injury, and ketoglutarate to have as a metabolic source of energy. So that's the composition. If you want to go down to the biochemical level, that's the composition of the solutions, both UW and STK, which are the most common solutions being used in the country or across the world for organ preservation. And just to mention that, although it's said that STK is probably better than UW in situations where you are anticipating a prolonged cold ischemia time beyond 24 hours, whatever experience we have at our center, like in India, the cold ischemia time rarely exceeds 12 hours. So in these situations, they probably work the both. But if you have to use it, then probably it's better to flush with STK. STK is like, it's less viscous. It's has as low viscosity as water, so rapidly flushes the organs. And probably if you want to store, then UW is maybe better or same as STK. So coming to the next part of my talk, donor selection. So as Sonal highlighted that there's very little, virtually everybody is a donor, and there's no age limit as far as liver, kidney, pancreas, as liver and kidney transplant is concerned. But if you talk about the pancreas is a very the donor selection here is the most conservative. It's a very fragile organ, and as general surgeon, you are always taught that do whatever you want, but never go near the pancreas, right? So so that the same philosophy is here with the selection of the donor, that it's quite a rigid criteria that you limit your organs to the age between 8 to 50 years, and you definitely do not want any obese patients. So ideally the BMI should be less than 30. Any patient with a high BMI is prone to have a fatty pancreas, which can cause a lot of trouble for the recipient down the line. And if you have a cause of death which is not related to trauma or tumor, they have an adverse outcome especially the patients who come with a stroke or with the intracranial bleeds. You need to assess your transaminases and amylases, especially if the patient donor has had a history of cardiac arrest or he was in severe hypertension. We've had situations where we've had to analyze these serially as well, because one reading may not be enough. Like if the patient has had a cardiac arrest and could not be resuscitated in time, and the first reading may not be, you may not have given enough time for the transaminases to be raised. So you should always follow it up with the serial reading, maybe 6 years or 6 hours or 12 hours down the line, to confirm that there's no severely rising trend. Patients who've had a prolonged ICU stay are quite prone to have colonization with an MDR organisms. And we know that in pancreas transplant, the organ is highly prone to develop collections around the pancreas, and which can be infected. And if you have an MDR organism, you can be asking for a good deal of trouble. And always remember that the recipient of pancreas transplants are one of the most fragile ones in terms of their vascular disease. They're like type 1 diabetes for many years, and they've got widespread calcification, plaquing of their arteries, and their tissues are otherwise also like they are ischemic. So, you need to have a good organ to have them out of the critical state as quickly as possible. Intraoperatively, as with the assessment of liver, you need to assess the pancreas as well. Any fatty pancreas should not be transplanted. Any fibrotic or a smaller pancreas again should be discarded without any second thought. If the patient has a fatty liver, that's an indirect marker of the pancreas being fatty, as there is a close correlation between the two. So if you talk an ideal pancreas donor, so you should be targeting a cold ischemia time of less than 12 hours. He should be on minimal inotropic support, because we know that pancreas is a low flow organ. If you have very high inotropic support in the ICU, you can develop ischemic changes in the pancreas, which can cause severe pancreatitis, which is a harbinger of further complications. Active sepsis is a contraindication for any organ utilization, and DBD donor is the ideal one, although you can do pancreas donation after DCD as well. And as far as kidney transplant is concerned, many people will restrict the choice of donor to less than 70 years of age, actually, or maybe less than 60 years of age if you're more restrictive. But we go with the philosophy that you actually evaluate each person as he comes, check their kidney function, check their urine routine examination, and if the kidney function is normal, if the urine routine is normal, there should not be any contraindications as far as the age is concerned. At the most, what we follow is that if the donor is more than 60 years of age, if there is and if he has some comorbidity, we do not transplant a single kidney. We do an en bloc transplant where we put both the kidneys in one recipient. Of course, the only contraindication of a kidney transplant, kidney donation, is that the donor should not be suffering from any renal disease. And these are the exclusions as already being mentioned by Dr. Sonal. So absolute contraindications are very few. The possibles which are evaluated on an individual basis include the viral status of the patient, but we know that HIV used to be a contraindication, it still is, but then you can use organs from HIV donors to HIV recipients, and it is not that is only described in the literature. Transplantation of patients suffering from HIV does happen, and in the last year only, we have done two patients with HIV infection have received organs from deceased donor at our center only. Hepatitis C used to be an incurable disease, which has certainly become curable by presence of highly active antiviral drugs. So it is no longer a contraindication. Earlier, we used to allocate organs from hepatitis C patients to hepatitis C recipients, but now they can actually be given to hepatitis C negative recipients as well. diabetes is obviously a contraindication as far as the pancreas is concerned, because that's what you're trying to cure. But for the kidney, we have used, a lot of centers have reservation against using organs from diabetic donors. But if you evaluate them, if they do not have any overt diabetic nephropathy, means that there is no urinary protein excretion, then you can safely take up these donors. But always remember that they should preferably be allocated to patients who do not have diabetes, because it's been shown that if you have microvascular involvement of diabetes in the kidney, and if you transplant it to somebody who's euglycemic, those changes can reverse. But once you have an onset of proteinuria, then it's a clear-cut no. So this is a very busy slide, so I just included just to show you that what happens on the day of transplant. So many things, so many teams, so many people are involved in each organ donation and transplant, that you are actually, and there are so many factors to assess. So it's a very busy time. So you need to not only evaluate the demographic factors, you need to know the cause of death. You need to know what are the pre-donation events in the donor, how has he been managed, was his sodium appropriately corrected, was his intravascular volume normal, or he remained ischemic, did he remain hypotensive, and how many inotrops did he receive. There's a concept of downtime if you are doing a DCD donation, that the patient had a cardiac arrest and how much time did elapse before we actually could take the donor's organs and put them into the eyes. So you definitely have to look at the lab reports. You have to check, exclude any infection, malignancy. You have to be within the permissible limits of cold ischemia for each and or organ. You have to see for any visual damage to the graft, and you have to do the matching with the live donor, the coordinators, the recipient teams as well. So I think the donor operation has been well covered by Dr. Sonal, so I will not repeat all the steps. I'll just briefly say that you've got multiple teams operating in that one theater. Like one theater would probably be occupied by more than 20 surgeons when an organ donation is happening. And you may have a separate team for cardiac, lung, liver might be a separate team, pancreas again, and kidney team. So everybody might be there. So each of the teams should coordinate regarding the steps, whether you want to do an sternotomy, even if the heart is not being retrieved, what steps of cold phase and what steps of warm phase. So each surgeon has an individual choice. There are surgeons who will not do any warm dissection because of the thought that any warm dissection will lead to some vasospasm and cause ischemic insult to the organs. So there are surgeons who will just do a cold perfusion, and everything, all dissection they will do in the cold phase, whereas there are surgeons like us who will do everything in the warm, and there are surgeons who will do a mix, some part in the warm and some. So all that needs to be discussed amongst the various teams. Portal perfusion through the portal vein is sought for by many of the liver transplant surgeons, but if pancreas is being perfused, then it's a strict no. And you should talk about where the aorta is going to be clamped. You can clamp it in the chest. You can clamp, as Sonal showed, just subdiaphragmatic. And if it's only kidney which is being perfused, you can even go further down just below the level of SMA. And then the IVC clamping, and where the bleed out is going to happen. So you can have the bleed out in the thorax, which is preferable that your field stays clean. It doesn't get all that blood inside the field. Or you can do the bleed out by putting a suction catheter in the lower IVC, or if that is not feasible, you can just give a nick in the infrahepatic IVC, especially if only the kidneys are being retrieved. So while there are a lot of variations in the method of technique, but the order of organ retrieval is very strictly followed. That heart and lung gets the first priority, followed by liver, pancreas, intestines, kidneys, and lastly the corneas. So I think this is probably Sonal has already discussed the laparotomy and the mobilization of the right colon. So I'll just skip it. So this is just to show that the laparotomy, the exploration, what you do exploratory laparotomy. So that's the lesser sac which has been opened up, and you see the pancreas. There is no fat. You can see the globules, the pancreatic globules very clearly. There's no fat involved, so that's an ideal fit pancreas donor. And as Sonal said, that there is a lot of surprises while doing an exploratory laparotomy. So this is a picture we taken last year, that the donor had an AKI, that he had some hypotensive episode and his creatinine was high. But as we know that if it's an acute kidney injury, and if you do a transplant, the AKI reverses. But to our surprise, that this donor had a complete cortical necrosis of both the kidneys, and the kidneys are looking black. And when we took them out, there's no vascular supply. They're totally thrombosed, so we had to discard. So always do a full exploratory laparotomy before you go to the organ retrieval. So rest of things I'll just skip, just to mention that while you are taking control of the lower aorta for perfusion, you should always identify ureters at the pelvic rim so that they do not get injured. And you should take care of any lower polar artery. So kidneys may not have a single artery in all patients. So up to 20% of the patients have multiple renal arteries, and sometimes a lower polar artery can arise as low as the common iliac artery. So as a dictum, I always tell my residents, whenever they're going for retrieval, any lateral branch arising from the lower aorta should not be ligated. Only the anterior branches can be ligated. So any lateral branch, you should assume it's a lower polar artery, and you should cannulate the aorta lower than that. So that's just the diagrammatic representation of the lower aorta and the IMV controls being taken. And this is again the same picture which Sonal showed. The IVC here, the aorta here, and the IMA has been ligated and trying to pass a vascular sling along the aorta. And that's the supraciliac aorta which has been taken control of. And then comes to the warm phase dissection, which Sonal showed in great detail. So just to briefly, as far as the kidney part is concerned, you just have to expose the renal capsules both anteriorly and posteriorly, so that remember that kidneys are the last organs to be taken out. So it can is the after clamping, it can easily take up to 1 hour to get the liver and the pancreas out. So which means that the kidneys are sitting in suboptimal cold conditions for more than 1 hour, and you should make sure that you expose both the surfaces, and both surfaces are the ice is kept on the organs so that the organs get cooled nice and pink. So as I just showed that before you start for the pancreas retrieval, you should always inspect the pancreas in the lesser sac. You should mobilize the splenic flexure and the descending colon, which normally we do not need to do if you're only doing the kidney alone, or you're doing the kidney and liver retrieval. So you need to mobilize the splenic flexures, which allows you exposure of the tail of the pancreas and spleen, and allows you can apply the ice to both the organs after cross clamping. And you mark the proximal and the duodenum and the proximal jejunum where you are going to staple both the organs. So I'll just show you a picture of. Okay, and apart from that, you need to identify and loop the vascular structure. So the pancreas gets its vascular supply from the superior mesenteric artery, the splenic artery, and the drainage is through the portal vein. So all these structures has to be identified, and the pancreas comes en bloc with the spleen, with the duodenum, on the pedicle of SMA, splenic artery, and portal vein, right? So not only you are taking out the pancreas, we're also taking out the spleen, we are also taking out the duodenum. And those the sites of duodenum where you have to staple it are marked prior to starting the cold phase dissection. So that's the renal vein, and this is the SMA which is being dissected, and that's the SMA which has been looped. So I think Sonal talked about the left hepatic artery. I'll just skip. This is one of the pictures which showed that this is the celiac axis, the splenic artery, which is always dissected, which I always dissect in the warm phase, which goes to the pancreas. And you can see that there's a branch coming from the splenic artery going into the pancreas. So you always have to be careful for this LT branching, because if you divide the splenic artery, you might not flush with the celiac. If you divide it slightly down there, you are liable to injure this artery. And this is the left gastric, and this artery is the left accessory, left hepatic, which is arising from the left gastric artery. So in this situation, the liver always has a priority. If there is any situation where there's a common blood supply, the liver always gets a priority. And I will not talk about the accessory right hepatic. So I think portal dissection has already been said about by Dr. Sonal. So once you have done the clamping, then the cold phase starts. And so what do you want to do with the pancreas? You just want to transact all the vessels. The portal veins already been transacted. The celiac axis is already gone with the liver, if the liver is being taken, and the splenic artery is cut flush at the site of origin from the celiac axis. And the marks where we have marked the duodenum, you just put the staples and transact them. And after that, you just lift the spleen along the tail of pancreas and dissect it out from the body. As far as the kidney is concerned, we just split the aorta, and either you can take them en bloc, or you can split the aorta in the midline, inspect the orifices of the renal artery, and then transact the aorta both superiorly and inferiorly, and take the kidneys individually. So I will just skip this, already been covered. So that's the portal vein. So always ask the liver surgeon when he's trying to disconnect the liver, you always need 1 to 2 centimeters of the portal vein with the pancreas if you want to implant the pancreas in the recipient. So this has already been covered. So as this is, as I was telling you, that the pancreas doesn't come alone. It comes on a stump with the splenic artery, the SMA, SMV, portal vein, the spleen, and the duodenum, and these are the areas where finally the duodenum is this 8 to 10 centimeter of the duodenum is what goes in the recipient, and the rest can be discarded on the bench. But when we put staples, we try to identify the pylorus, and we put the staple just distal to the pylorus, and on the jejunum we put at the first part of the just where the fourth part of the duodenum finishes, we just put the staple there. And once you have put the staples, the only thing what is left is the small bowel mesentery, which also needs to be stapled. Remember, this is the SMA rising posterior to the pancreas, and then it comes inferiorly and leaves the pancreatic lower border of the pancreas. So this part also, this is in the mesentery, and this part also has to be stapled when you are taking the pancreas out from the patient. And once you've done all this, you just lift the spleen and use it as a handle. You do not fiddle with the pancreas. You do not handle the pancreas. Just use the spleen and bring it to the midline. So that is what you have in the bench. That you have the splenic artery, the SMA, and the portal vein, and this is the CBD which has been ligated. So the last part of my talk was the organ allocation. So, I mean, Sonal talked about MELD score, but there is no scoring as far as the kidney and the pancreas is concerned. So it is done as per the waiting list, with some preferences being given. Like this is what we follow at our center, that if you have a marginal kidney means that any donor who's more than 50 years of age, who's died because of CVA, or who has diabetes, or who has more than 10 years of hypertension, so we call it as a marginal donor. So they are allocated only to recipients more than 50 years of age, because we know that these kidneys are not going to work for long, and we need to give it to somebody who has a limited lifespan. And multi-organ recipients, like if you are requiring both pancreas and kidney, or liver and kidney, they always receive priority in allocation of one of the 2 kidneys which comes out from a particular donor. And so this is the organ allocation system what we follow, that for each month on dialysis you are given 1 point. So we prioritize children. So children who are less than 15 years of age, they are given about 20 months of waiting period to advantage. Same is the case if you have a failed living transplant from a living donor. You again get some advantage. There is something called a sensitized patients, which means that they are not compatible with most of the donors. So you give them some advantage in the sense that they will be matched only to a few patients. So if they are matched, you give them an advantage of about 30 months of waiting period. Then to promote organ donation as a center, we have taken that policy that any patient who has donated an organ, their first degree relations in future, if they develop kidney disease or if they develop any end organ disease, they will be given 40 months of advantage, which we thought that if somebody is given a gesture and given life to so many of them, I think that's the least we can do for them. So we put this proposal across the country, even to our national authorities, but unfortunately they did not agree to this 40 months of advantage, and they limited it to about 6 months of advantage for this purpose. And lastly, any living donor who presents with an end stage renal disease, we give them 50 points of advantage that during his life that this donor has actually donated his organ without any reason, without any not without any reason, but without any obvious advantage to him. He's undergone a surgery, a major surgery. So we thought that they should probably be given advantage to the fullest, and so they are given almost 50 months of advantage, which almost puts them on top of the list at our center. So organ allocation is all about equity. So we need to maintain that equity. At the same time, we definitely have to give certain leverages to certain categories of patients so they are not disadvantaged. So I think for the surgeons, I'll probably leave this sensitization thing. And if time permits, I have the video as well. So I'll just ask Chirag if we have time.
Yeah, you can show one or two videos.
Okay. So I think I'll just go briefly through these. So I mean, we always make a sternotomy. So while we are doing the organ retrieval, so what it does is that it gives you very wide exposure. So then you can easily your dissection is much easier, especially while you are taking the upper aortic control. It is much easier. So and many times, how to do a sternotomy, you need a sternal saw. So many times you don't have the sternal saw. So we've been using this giggly saw, I think, which is easily available.
Ashish, can you change your screen share? I think it's still showing a PowerPoint.
Okay. Sorry for that.
Yeah.
So you stop sharing the PowerPoint, then on the screen then again share again the video. The video will show up on the computer screen, which will right.
Okay. So I mean, we always give the full incision from sternal notch to the pubic symphysis, and it gives a very nice exposure. So a lot of time people say that we don't have the sternal saw, so how to do it? So even if you don't have the sternal saw, I think giggly saw is very easily available. So you can use that. It's doesn't cost you a lot, and you can easily split it with the giggly saw. So the advantage of using the full sternotomy and laparotomy is that it gives you the best exposure. Anytime if you are in trouble, you can just pull the lung out of the thorax and clamp the aorta there, and the lower thing you can start the perfusion. So that's the laparotomy being performed. You actually check all organs, starting from the right iliac fossa, go in a clockwise manner, go to the liver, then go to the spleen, pancreas, stomach, and then the intestines. So just go and check everything, just to emphasize that. And then this is the mobilization part. You start the mobilization of the right colon, and once you mobilize the right colon, you will see the iliac vessels down there. Yeah, so that's if you see that, that's the so that is that's the inferior mesenteric artery which has been ligated, and you see this is the aorta, the lower aorta and the common ilex. So once you ligate the inferior mesenteric artery, the next structure which comes to your field is the left renal vein here on the left side of the screen. And once that's your limit of the dissection, that you reach that area, and then you just go and take the control of the lower aorta. So it's
Dr.
important to
Ashish, I
ligate.
think the video is not moving forward. It's stuck on the first picture.
Okay, maybe it's something to do with the bandwidth. So
do you have any other video, or we can?
So if you want to see the pancreas retrieval, I have that, or if you can just.
I think that would be great if you try that. If that video works properly, then we can see that. Otherwise, we can just move.
Okay, so is it like? Can you see that now?
No, the first video's first picture is there.
Okay, so maybe I'll just again do the
You
sharing
stop
again.
sharing and share the new video again.
Okay, so is it? Can you see now? Is it changed?
Yeah, we are able to see something.
Okay, so that's the left colon which is being mobilized. So what we do is that we get the bowel out of the field once the cold dissection starts. So that's the first thing we do, that get the bowel out of the abdominal cavity. So that helps you to focus on the organ. So as I said, that this is the jejunum, first part of the jejunum, which is being stapled. So to free the pancreas, right? So once you've done that, then you lift the rest of the bowel inferiorly, and then this is the mesentery which comes below the pancreas, below the lower border of the pancreas, and that also you put a stapler there. So once you've done this, the whole of the bowel can be just, if you see that your abdomen is now pretty clear, and that's the upper part of the first part of the duodenum just below the pylorus. That's the third staple which you put. So once you've done that, your bowel is the pancreas is totally free. And now in this case, the liver was not being taken. So the splenic artery is going to be, so that's the splenic artery being cut from the celiac axis. And now we go to the portal vein. So that's a portal vein being dissected. It's already been dissected. So this will be cut about 2 centimeters, 1.5 to 2 centimeters. So you can say it's been nicely perfused, and clear fluid is coming out from the portal vein. So that is the portal vein which has been cut. This is the liver end. So the liver in this case was not utilized. And then the rest of the tissues can just be cut. The CBD has already been ligated here. And this is the SMA. So that's the last structure which is now left. So this has already been, as I showed, that dissected out. And so once this is cut, so the pancreas is free from the vascular pedicle and the bowel connections. And then you just need to pick the spleen. So there's a lot of thick tissue around these vascular pedicles. So if the identification in the cold phase is very difficult if you've not done the dissection in the warm phase. As you can appreciate that there are a lot of thick lymphatics around this area. So, but if you have vascular control with you, you can just blindly cut them. So that the stomach being lifted up, and now the spleen is being used as a handle, and the posterior attachments of the pancreas are being taken away. So spleen is in the hand of the surgeon, the operating surgeon, and these are the posterior attachments. So there, once you have got your vascular pedicles safe, then you can just go blindly and just cut everything else. You have short gastric vessels, but that you can all between the stomach and the pancreas along the superior border, but that you always can do take care during the bench part. So as you can appreciate, there is still a lot of thick tissue lymphatics. So that's the importance. I want to highlight that just have the vascular controls, and then your pancreas retrieval can only take 5 minutes. So I think with that I will end. If you're interested in the kidney part also, I have the kidney videos also. But if you want me to stop, I can just stop.
I think we move on to next talk now.
Sure.
So you stop sharing your screen, and Jay, you can start sharing your screen.
Yeah, so a lot of internals and blood for a day for me. Thank you so much, Dr. Desai. But huge respect for what you all do. I am a kidney recipient myself, so I know what that means. All right, so I'll share my screen. So I'm to talk on organ donation awareness and training. So I'm going to talk about the interventions that Mohan Foundation has done to augment deceased organ donation in India. So Mohan is actually an acronym for Multi-Organ Harvesting Aid Network. As you all are aware, the organ donation scenario in India, there's a huge gap between the demand, the need, and the availability of organs. Annually, we have more than 10 lakh people suffering from end-stage organ failure, but only about 10,000 of them receive life-saving organs, and this 10,000 also includes the living donor transplants. So where does India stand as far as the world map is concerned? We have Spain leading the world map with almost 49 people per million population, whereas India is not even 1 per million population. We all know that one organ donor can save up to 8 lives through organ donation and heal up to 50 or so through tissue donation. So Mohan Foundation was launched in 1997 when the Transplantation of Human Organs Act was introduced in 1994. Post that, it's started by Dr. Sunil Shroff and a few other like-minded individuals. And its mission was to ensure that every Indian suffering from end-stage organ failure be provided with the gift of life through a life-saving organ. So Mohan Foundation essentially started off more than 2 decades back, and they started talking about organ donation at a time when it was probably a taboo topic, and it must have been so difficult to break ice with the general public. However, over a period of time, multiple awareness initiatives have been taken. Today we have 9 offices spread across the country, and almost each and every office is center is extremely busy with so many multiple awareness initiatives, be it at schools, at colleges, at corporates, offices, at residential complexes, stalls, walkathons, you name it. Even at wedding ceremonies we get invited. So that's the people are wanting to know more and more about how these things work, and they want to do everything with the purpose and with the meaning. So that's how the awareness levels have gone up quite a bit over the past years. We've also had a few celebrities talk about organ donation, because it's always so much easier when these celebrities talk about it. The reach is amazing and mind-boggling. We've had a few media partnerships who have actually helped catalyze mass awareness. The notable ones are the Times Organ Donation Drive, powered by Kokilaben Dhirubhai Ambani Hospital, or the More to Give campaign by Fort, where we are the NGO partners or the knowledge partners with in both of these mass drives. I would like to share with you all as to, while we started off primarily doing a lot of awareness initiatives with the public, we realize that just engaging with the public is not going to help. We need to start engaging with more stakeholders in this program, and therefore we started working with the state governments. We started working with state governments to pass favorable government orders, to also place our transplant coordinators in the government hospitals, so that they can sort of within the hospital they can start building the ecosystem which will either help initiate or help augment the disease donation program. We also work with policymakers as well as the hospitals. So awareness, B, training. I'm going to speak a little bit about the training in the next slide. We do counseling. Our own grief counselors are placed in the government hospitals wherever we have tie-ups with the state governments. And of course, networking between the organ sharing organizations. This is also extremely important, and we sort of play the bridge between all of these bodies. So a little bit about the training program. So we started off with the transplant coordinators training program way back in 2009. And thereafter, that was a time when nobody was conducting such training programs. And over a period of time, we've trained more than 2,400 transplant coordinators across the country. And it has now become the gold standard. And we have more and more bodies now following this independently as well. So while the cadre of transplant coordinators are trained by us, and they are essentially taught to know the legalities, they are trained to trained in the skill of grief counseling. It's an art, and it has to be acquired. There's training that has to be well understood. So these transplant coordinators play such an important role in facilitating an organ donation, and therefore it goes without saying that training these cadre of people is extremely crucial for transplants to happen successfully, for organ donations to happen successfully. But then we went on to realize that just training transplant coordinators alone is of no use. We also need to focus on the critical care doctors. Essentially, they play the lead role in facilitating an organ donation. Therefore, the ICU specialists, doctors, nurses, all of these, we began training that cadre of healthcare professionals as well. Transplant surgeons, well, yes, we've been conducting this with Dr. Sonal Asthana, and basically training surgeons in multi-organ retrievals and transplantation. We've also been training surgeons, aspiring surgeons in government hospital, and we've done it free of cost for them so that they can acquire the skill set. And we've had some beautiful success stories whereby heart transplant was done in a government hospital post this training. Another gentleman did a hand transplant post this training. So that's the beauty of this. We've also reached out to a lot of medicos, paramedical staff, the nursing staff, and done quite a bit of awareness in that. A little bit about our e-learning course. So transplant coordination training comes in multiple formats. It would come in a 1 week long program. It would come in a 1 month long format. And also we have the 1 year long e-learning, learn at your own pace online course. And the wonderful part of this is that we've had not just people from India, but from the neighboring countries, from the SAARC countries also reaching out, and they have enrolled themselves. And we're seeing now with this corona pandemic, we're seeing a huge demand for this e-learning online course. We've also reformatted the 1 week training to make it available online. And so we're starting with this in the next week. So what do these transplant coordinators do? Essentially, they do the difficult task of counseling the families and asking them and motivating them for organ donation. And we've seen some successes coming through. These are through our own transplant coordinators. And therefore, we've seen that day, while we started off at Tamil Nadu, we've spread, and we've sort of played the bridge between various passionate stakeholders. We started working with the Tamil Nadu government, the Karnataka government. We've been working with Telangana, with Maharashtra, with the Rajasthan government. And now you see the small little patch on the right at Manipur. So happy to say that we are working with the Manipur government so that even the citizens of Northeast can be benefited by this medical advancement. So overall, more than 60% of disease donations in India have been facilitated through our various training formats. As you all can see, over the period of over the last 5 years, over the last 7 years, the deceased organ donation rate has increased 5 times. We also have a national organ donation helpline, which not just which actually started off as an information giving tool. However, the beauty of it is now it has started even facilitating and coordinating for organ donations, tissue donation, of course, yes, but even for organ donations, and it's been amazing. We also coordinated for a donation through at Dubai through this helpline, so that's amazing. Some of the technologies that we have developed at Mohan Foundation. So these are the apps that we have developed. The first one is an organ donation counseling app, which is basically an entire database of all the eye banks, skin banks, body donation centers, NGOs, what is the law about. So all of these are available here. We also have the organ donor optimization app, which has been developed in partnership with the NHSBT UK. We also have the brain death testing and certification app, which we've developed recently. And of course, for the general public, we have the Pledge Your Organs app. Adding to the technology, we have organ sharing web registries that we have made available for, we have a tie-up with Tamil Nadu, Kerala and Rajasthan, whereby this sort of ensures fair, equitable and transparent distribution, no manual interventions. So this we provide the back-end support by offering this technological services to the governments. One of the major landmark in the efforts of Mohan Foundation was that we've been lobbying with the government quite a bit, and finally we saw a breakthrough in this, whereby the Indian government has included the option for the public to add the organ donation wish in the driving license. While we were all very excited with that, but the implementation has been very slow. And now recently, it's about 15-20 days back, they've actually made it compulsory that in the driving license, when one fills the form, they have to mention either a yes or no, otherwise it would get skipped immediately. We've also done some mass awareness, some very innovative awareness by lighting up some of the monuments across the country. For example, Qutub Minar was lit in green. We had the CST station in Mumbai in support of organ donation, especially on National Organ Donation Day, CST was lit up. We also had the Life Before Ashes, which was an award-winning traveling exhibit. So these exhibits that you can see on the top, that's the eye, the liver, kidneys, heart and the kidneys. So these exhibits were made from real human ashes and mud from the graves. And the message that they gave was that these organs had the power to save a few lives, but they were, however, burnt or buried. So it's a little bit hard hitting, but it was very well received and got a lot of coverage, and people got to know more about organ donation through these innovative awareness campaigns. Some of the awards and accolades, some shining moments for us. So please do join us in our endeavor to ensure that no Indian dies for want of an organ. Thank you so much.
Thank you, Jaya, for a very comprehensive talk. And
Chirag, I think we have
yes,
completed. The other next speaker is waiting. It's 8 o'clock.
Yes.
I think it's a wonderful discussion. We wish it was this long. Would have had a longer time, and I'm sure that the followed by a very good panel discussion. Thank you. It's a lovely lecture and it's very, very informative to this platform. Thanks for all the efforts. Thanks, Sonal, thank Ashish and Jaya. Thank you so much.
Thank
Thank
you.
you, Dr. Adar.
Our
Thank you,
pleasure.
Chirag.
Thank you. Thank you, Dr. Chirag.
Thank you all. Thank you.